we'd move on to our keynote presentation for this session, which is by Dr. AUDREY ROSTOV. She's the Director of Cornea, Cataract and Refractive Surgery with Northwest Eye Surgeons in Seattle. She is a presenter of various international fora. She conducts the Refractive Surgery Day at the Ascaris, and she has toured India widely. And I think just as her presentations are very informative, she carries the Indian attire also with a lot of grace. On to Dr. AUDREY. Her topic would be cross-linking complications.
Great. Thank you so much. It's wonderful to be here and to see everybody in person. These are my financial disclosures. I am a consultant with Glaukos that does make a cross-linking device. As we know, there's epi-on and epi-off cross-linking in the US, which is where I am based. We have our FDA is approved for epi-off. I have been involved with clinical trials for both epi-on as well as epi-off. The complications of cross-linking are, of course, well known to us, and I'm going to go through these and discuss some treatment. Infectious keratitis is probably the most common cross-linking complication, and of course it comes in the usual varieties with the usual suspects. This is a patient who had staph coag positive bacterial keratitis. This was a patient of mine treated with fortified vancomycin, and this resolved nicely in a few weeks. The nice thing, in a sense, if there is bacterial keratitis and it's successfully treated, is you often get more flattening of the cornea, so that can be an unexpected bonus. Alpha strep keratitis is another fairly common etiology for bacterial infection. Hsv keratitis, early on when I was in the epi-on cross-linking trial, I actually had a patient that I had, as you can see here, had intrastromal corneal ring segments and developed bilateral Hsv keratitis following epi-on cross-linking, treated with oral valacyclovir and topical ganciclovir, and this resolved in a little over a week. Again, there was more flattening. With HSV infection, of course, can occur after cross-linking. It makes sense. It's UV light. There have only been a few cases actually reported in the literature. If someone has a history of active oral HSV or frequent oral HSV and or atopic disease, I would consider prophylaxis with PO antivirals. Prompt treatment, again, and prompt recognition can lead to good outcomes. Acanthamoeba, of course, has also been a dreaded complication, just like any sort of epidefect. My experience at my center, and I've done about over 1,200 cases to date, epi-on was only about 300 or so, and then I've had about 1,000 plus of epi-off. I had 3 eyes of 2 patients, the one bilateral HSV that I mentioned, also a staph coag negative. Both patients resolved their infections without loss of best-corrected vision. For epi-off, I've had 8 eyes of 7 patients. What's interesting is that I saw a slight uptick once COVID hit, and I believe it was from mask wear. I think that if you look at the patients who come in and you see what their mask looks like, they really need some education about frequent changing of disposable masks and also washing of the non-disposable masks. In the literature, of course, infectious keratitis following cross-linking has been well described. Again, all the usual suspects and all varieties. Infection prevention, again, with HSV patients, oral and or ocular, consider PO antiviral prophylaxis. Caution in atopic disease because of potential both for HSV as well as bacterial superinfection in patients with bad atopic disease. And I actually put on a bandage lens and see the patient every 24 to 48 hours, including frequent changing of the bandage lens, again, to prevent infection. Perforation has also been described. There was a series of brittle cornea disease that there was perforation. Perforation has also been described in the literature due to microbial keratitis as well. So this has been a hot topic that has just been discussed with the last paper. What about corneal pachymetry under 400 microns? This has not been associated with perforation or endothelial harm. For at least the glucose device, it is approved for corneal thickness greater than 400, and as we discussed, you can use hypotonic riboflavin to swell the cornea. That works quite well. There is in the literature, cross-linking has been performed for 300 to 400 microns using the hypotonic riboflavin and has not ended in endothelial damage. Delayed epithelial healing due to dry eye disease can also occur in epi-off cross-linking. If you have a patient who has dry eye disease, and of course they can get an increase in dry eye following, you want to really be careful. Make sure that you are lubricating the eye a lot, and this could take just the usual, artificial tears. You may need to use ointments, patching, even amniotic membrane. I use amniotic membrane actually to help resolve these defects if the usual things don't work. I've also used Synergermin, that's by the Italian company Dompe. They have approved for neurotrophic keratitis, and they have the nerve growth factor, and nerve growth factor can also be helpful in very stubborn cases. Corneal haze, another complication. This can occur just on its own. We all see a little bit of that. I call it healing haze following cross-linking, which we're all used to seeing, the healing haze, and that usually goes away by about a year. Most cases don't affect vision. There have been some cases, though, of late haze, almost like a central toxic keratopathy that you can see with PRK or LASIK on occasion. I've actually seen this in a couple of patients who had post-LASIK ectasia and then a few months later developed significant corneal haze. The important thing if they do have significant haze is essentially to treat them with topical steroids very, very aggressively. And with prompt treatment of topical steroids, you can get a very, very nice response. It can take several months of steroid treatment, however, but I would say to be aggressive. I've even used a short course of oral steroids as well in one patient. I believe she had some kind of traumatic event a few months later, sort of like we would see with the DLK kind of look to it as well. Again, haze prevention. Basically, prevention is sometimes your best cure. Prevent and avoid delays in epithelial healing by treating dry eye disease aggressively, and again, aggressive topical steroids. What about progression? Risk factors for progression, of course, include young age, eye rubbing, high preoperative Ks. Progression rates in general, I quote, about 3 to 7%. I tell patients when they come to see me that they have a 90 to 95% chance of having just one cross-linking procedure, and there is a 5 to 10% chance of progression. This was a patient of mine, a 15-year-old who came to see me with keratoconus, and so as we heard from the first talk, when to treat. Unfortunately, this patient did not come back, and then over the subsequent 2 years when they were seen, really ended up with significant progression. I really like looking at difference maps rather than just a K-max. Sometimes you can see a steepening and you don't know if it's epithelial remodeling or if it's real. You have to look at epithelial maps as well, but I really like the difference maps because you can see more of what's going on in the cornea. Of course, always, always, always ask about eye rubbing, and then dive a little deeper into why they rub their eyes. Is it because of allergies? Do they need treatment? Is it dry eyes? Is it habit? Really inquiring as to a deeper dive as to why they rub their eyes can really help your patient as they try to eliminate that behavior. A last issue is epithelial ingrowth. I've seen this several times with patients with history of LASIK and post-LASIK ectasia. You have to be careful when you are removing the epithelium in epi-off cases because you can still lift a flap edge, especially of a microkeratome flap years later. We all know that there's cases of trauma following following LASIK years and years later, and it is traumatic, of course, to do the surface removal of epithelium, so you can get, in fact, epi-ingrowth. These were two cases. You can see that right at the edge there was some significant epi-ingrowth. So what to do? Well, if it's just peripheral and there's a demarcation line, you can just observe and you don't have to be that aggressive and lift flaps and treat. I find these flaps can kind of be rather more difficult to lift, as well as issues with being able to get the flap to lay down properly and to prevent recurrence of ingrowth. I've done YAG treatments with a YAG laser for epi-ingrowth, and I find that that works really quite well as being minimally invasive. I start with a millijoule and I increase as needed. You basically YAG all the cells until you see them clear, and also this can take several treatments. So in summary, educate your patients to avoid dusty, dirty environments, good hand washing, and in this COVID age, of course, change masks frequently. Treat haze aggressively using post-op steroids. Treat dry eye disease. Sometimes the best treatment is prevention with lubrication, anti-inflammatory meds, some topical steroids, punctal plugs, amniotic membrane if that's necessary. And if you do get epi-ingrowth, you want to watch this, especially for patients with a history of previous LASIK. It can result in some scarring. Thank you so much.
Thank you, Dr. Rostov. It was really very educative, and I mean, many of these complications we have seen, and very nicely presented the management options for all these. Please take a seat. We will have, we have a question here.
Good morning. Ma'am, please. What is the percentage of your cases with posterior lenticonus keratoconus only been treated for C3?
Sorry,
how frequently do you treat posterior keratoconus only, and there is no anterior signs or topography negative thing?
I'd say it's a relatively smaller percentage. You know, it really depends on why you are treating, right? And so if it's a young patient, you know, treat fairly early because you know they're going to progress. If it's an older patient and really you're just seeing some posterior signs, I pay close attention to the epithelial map because as we know, the first signs of keratoconus actually occur anterior. And so if you're seeing the anterior changes in the epithelial map, then I would be more likely to treat and more aggressive. If it's isolated, just posterior changes and not much is happening, then I'm not too excited about it. And so I'd say a relatively smaller percentage for treatment there.
Do you wait for some progression or those cases?
I would say it just depends. So it depends on what the goals are. It depends. I don't think you have to wait for progression. I don't necessarily absolutely wait for progression. I see what the goals are. You know, if they're able to have good best corrected vision, then I don't think there's any rush to treat. If, however, it's an issue and you want to get the patient back into a contact lens or something like that, then I think it's certainly reasonable to treat. I've also done a number of cases where I've done cross-linking and then I do topo-guided PRK as a refractive procedure to help them get better best corrected vision, not to be glasses independent or spectacle or contact lens independent. It's to actually help them be able to achieve good best spectacle or contact lens corrected vision.
Thank you.
Thank you. Now we move on to the next talk, and that is on intracorneal ring segment in keratoconus.
One question, please.
Okay, yeah.
Can I go ahead? My question is individualizing the fluence for cornea is thinner than 400 microns while doing cross-linking. See, you can go even up to 250 microns. Any experience from the people on the diet?
Sorry, I think cornea is less than. So, sir, can you just repeat your question again?
Individualized fluence therapy, that means you monitor the fluence according to thickness of the cornea.
Okay.
Yeah, actually there's a study recently published by Farhad Hafizi group regarding the adaptive fluence. That's what you were asking, sir?
Yeah.
Yeah. So they have shown that, even up to 214 microns of thickness of cornea can be treated by, reducing the time period of exposure to UV rays. They have shown up to 2 minutes time of exposure to UV rays, it can be cross-linked. I mean, but they haven't studied the endothelium at all. They have just shown that there was no case of endothelial decompensation. But what was the endothelial cell loss, etc., that is not there in that paper. And that is how, I mean, these cross-linking are done in all young individuals. And there may be endothelial damage as well without causing decompensation, significant decompensation. So, I mean, that is a big fallacy in that. And maybe, I don't know how much we can be sure about the efficacy and safety of that procedure. Maybe with time we will be able to know. Any other comment?
Feel it is advised we should go through it, or as it is mentioned in the literature with good result.
Sorry?
No, sir is asking if it has been mentioned in the literature. I think it is a published study.
It is a published,
Yeah,
it is published in American Journal of Ophthalmology by Farhad Hafizi group.
Unfortunately, that
Yeah.
software or whatever they use, they only have it. Nobody else has, corroborated on it. And I think future studies would be required to know how much it works and whether it does compromise the endothelium or not.
Thank you.